So yesterday we stopped at the boil law, and boil law is about the expansion of the gases. So has to do with the volume, and it's a volume within the chest. How you're going to have the expansion of the chest and the diaphragm during the breathing, breathe out. So usually for this boil law, you're going to use a kind of um, we call it container with glass, and you have a membrane in the bottom, and you have an opening that represents the trachea on top. And what you're going to do is to push down the diaphragm down, and you see, and inside you're going to have two balloons that represent the lungs. So when you expand the diaphragm, the balloon are going to expand with volume, and when you put up the diaphragm, the lungs, what represent the lungs, decrease, and that is going to represent the boil law with the differentiation of pressure and the movement of the airflow. So so you need to understand that in here that the volume is going to be inversely proportional to the container itself, and is going to measure the differentiation between the airflow and pressure. So this is why the formula will be pressure by volume that will represent the volume law itself. So the rules of diffusion of gas, these are very important to understand. This is about to make you understand how the oxygen will be exchanged within the alveoli and the capillaries. So you're going to have four main aspects of it. You're going to have the surface area, you're going to have thickness, you're going to have concentration, and you have distance. So all this, once again, is between the alveoli and the capillaries. So in normal lungs, you're going to have a certain size of the alveoli with a certain shape. And as we saw yesterday, compliance would be very important. Elasticity would be very important. And then you're going to have the capillaries that come with CO2 and go back with the oxygen. So you're going to have the pressure of oxygen represented. And you're going to have a spacing, interstitial spacing between the alveoli itself and the capillaries. Remember that in real world, you're going to have within capillaries the normal cell type 1 that would do the exchange. So this distance should be the same for all healthy individual. And why this distance is very important is because when the gas is going to diffuse through the cells, if the distance become very big, you're going to have the loss of the gases, so you don't have any exchange. So the health of the capillary as well. If you have a capillary that is not working, there's no movement of the cells inside it as the RBCs. You have capillaries that are too thick at the basal membrane, so you cannot have diffusion of the gases. All this is going to be affecting. Then with the alveoli, we're going to notice is just the so surface area need to be a certain amount of surface, and all of it need to be healthy. So remember that the exchange of gas starts from here and goes to the alveoli. So if you have any thickening or fibrosis, what's going to happen? No gas diffusion, and this is what's going to happen. So it means that the lung are going to be pretty much very smaller, and as the size goes. Concentration of the obviously of the gas are very important. So if you don't have enough oxygen, concentration will be low. If you have concentration very low, the diffusion or the exchange of gas will be very minimal for both sides. We saw yesterday as the pressure goes, so that will apply to the concentration of the oxygen and CO2. So, for example, in case of emphysema, what's going to happen is, so you have air that keep coming, but the problem is going to be the alveoli itself. Remember, in the emphysema, you're going to have fusion of multiple alveoli, plus you have fibrotic tissue. So the surface area of exchange are going to be pretty much very limited. Although the pressure of oxygen within the alveoli itself is going to be normal because the air comes normally. Sometimes it's going to be low if you have too much fibrosis, but usually it's going to be normal. But it's the exchange that would be an issue. So you don't have much of oxygen going. You're going to have a little bit that goes to the capillary, but not that much. And that is the issue of people that have COPD or emphysema. Now, if you have fibrotic tissue, the air keeps going as well. But the problem is you have a thickening of the alveoli by fibrosis. So anytime you have that, what happens is gas does not go nowhere. So the PO2 within capillaries are going to be low, although the PO2 within the alveoli itself are going to be normal. If you have an edema, so edema is water between the interstitial tissue, so the alveoli can be normal or not, so depending on the situation, and the capillary can be normal or not in the case of primary edema. But what's going to happen is the water between the space between of the alveoli and capillary. So all the gases that will come, what's going to happen? They're going to diffuse within this water, and very little to none goes to the capillaries. And this is why this is the reason why the edema is an emergency, because it's not only one area that's going to happen like this; it can be the whole lung. So the situation is to decrease the amount of fluid as soon as possible, and this is why you give furosemide as soon as possible, and the reaction are going to be immediate. And also, what's going to happen when you have this edema, the pressure between the interstitial would be so high that the capillary are going to burst. And the capillary bursting, this is why you have these whitish, foamy, pinkish materials coming from the mouth that look like rabies, really. The only difference is has nothing to do with rabies. So the oxygen that comes is going to be normal, so the pressure will be normal, but there's not much of pressure within the capillary because the gas is lost. In case of asthma, what do you have? Bronchoconstriction. Bronchoconstriction, remember asthma is not the breathe in that is a problem, it's the breathe out that is a problem. So you're going to have, this is why when you look at it under with the x-rays, exactly like emphysema, you're going to have hyperinflation. The lung become darker on x-rays. So bronchoconstriction do not allow the air to go through. So it means that you're going to have a pressure of oxygen that is going to decrease. There's not much of exchange, and that is going to. And remember, you're going to have a lot of mucus within the alveoli and the bronchi itself, plus the inflammatory process that is going to happen. So in that situation, in the severe cases of asthma, you're going to have the exchange of oxygen is not going to happen, and you're going to have ventilation that is going to decrease, caused by this resistance of the bronchoconstriction. And this is why all asthmatic patients, what you need to do is to give a bronchodilatator as soon as possible to allow the air to escape and to go out, and having the oxygen coming in towards the lung. So now the question is, what is the most severe asthma that can lead to death? What do you call it? What is the most severe type of asthma that can lead to death? That's my question. Deep. No. Jacob, you're correct, but you are incomplete as the name goes. So what is the rest? Okay, this is homework for you all. What is most severe asthma? Yakov gave you half of the name. Status epilepticus. Okay, found out and let me know. So the diffusion of gases, obviously, which we did talk about, you're going to have another law about it, which is the Fick law, which is it's the law of the exchange of the gases through the membrane, and so the membrane is going to be the membrane of the alveoli of the cells, the membrane of the basal membrane, and then basal membrane of capillary, and then the endothelial cells, and then the red cells with the membrane of the red cells. So that is diffusion of the gases. So this is why you're going to calculate it independence of the amount of volume that is going to be transferred per time, by unit of time, through the coefficient of diffusion of the gas. Each gas will have a kind of specific stable coefficients, and it's going to depend on the surface area of both alveoli and capillary, and then from there you're going to have differentiation between the partial pressure between the two gases, and then you're going to have the thickening of the membrane that will apply towards it. So this is why you're going to have the term or the formula that they can ask you different type of question about it. It's going to be Vx volume through the thickening of membrane. That is going to be the diffusion coefficient of gases, and that is depend on the gas itself that you're going to use. Multiply by the surface area, multiplied by the differentiation between partial pressure difference of gases that is going to do the diffusion, divided by the thickening of the thickening of the membrane, both of these membrane. So if you have an increase of thickness of membrane, the volume of exchange is going to decrease. If you have decrease of volume of the thickness of membrane, the volume is going to be increased. So this is why when you have fibrotic tissue, you're going to have a lot of issue of the diffusion of the gases because it doesn't go through the basal membrane whatsoever. So in case of eczema, you're going to have surface area that is going to decrease once again because all the alveoli are pretty much very destroyed. And this is a formula that you need to keep in mind as what will be the diffusion of gases, and you need to know that the diffusion of gases is the Fick law. So this is an answer of the questions that can be asked. And be careful for this type of thing and be any type of questions. So so you're going to have the some limitation, perfusion limitation for diffusion limited gas exchange for carbon oxide and natural oxide and CO2. So remember, for the all these exchange will go through the barrier, the alveolar capillary barrier, and the diffusion is going to vary because of the type of gases and the pressure of these gases that lead to the going through the basal membrane. So each of them are going to be different. Remember that the azote usually goes in, goes out without much of issues, so they're pretty much very free as the percentage of it that is going to move. And the it's going to be mostly a perfusion more than anything else. CO2 will be the same thing as the CO does a kind of net diffusion that's going to depend on the pressure of the gradient of the CO. This is why CO would be going very fast within the capillaries and binding very fast to the hemoglobin. This is what all these two means. The pressure volume curve. So this is something that is asked a lot as the graph for the USMLE. So the pressure volume, so one area, this is what will represent the vital capacity, and this is what will represent the pressure. The pressure goes from 0 to 40, and the volume goes from 0 to 5 liters. And from this type of value, you need to determine what will be normal versus what will be um, fibrotic, emphysema, etc. So this is what you're going to have three components here. You're going to have that the volume is going to be equal to the functional residual capacity. You're going to have the volume that will be lesser than the functional residual capacity, and you're going to have volume that will be more than functional residual capacity. So remember, by definition, that the functional residual capacity is the volume that you're going to find in the lung at the end of normal total volume. So it means it's a volume that is going to be constant, that is going to be there. Do not confuse it much with the dead space, because it looks like dead space. So it's something that is going to move, but it's going to stay as well at the end of the normal breathing. Normal breathing meaning tidal volume itself, which remember tidal volume, the value of it is 500, and it should not change. So then you're going to have the effect of it is going to be the airway pressure, as we saw yesterday, and the atmospheric pressure do not have any airflow. And when you have the volume that will be the same as the functional, you might have an issue of collapsing force from the lungs. So the lungs need to expand, as we saw yesterday. That is a normal reaction of expander, and that's why you need to have compliance versus elastance or elasticity. And then you're going to have a resting volume. This is a volume that do not move whatsoever at the end of the tidal volume. That is part of the dead space. And then so you're going to combine both of all this aspect of it. So once again, the volume is going to be the same as the functional reserve volume at the end. So now, if the volume is less than the functional residual capacity, this is going to be pretty much calculated at the end of the force expiration. And in that situation, as we saw, expiration, so you have less volume, volume is going to decrease. If volume decrease, obviously you're going to have the collapsing of the forces that maintain it open, and you're going to have an increase of the force of the chest wall to expand. That will allow the expansion. So if you combine all this, it means that you are ready to expand your lung. Now, if volume is more than the volume curve, that is inspiration, meaning you bring air inside. The barometric will be, remember, more. So the volume is going to be increased in that situation. All the forces of the lung are going to increase, which decrease expansion of the force of chest wall. Remember, there's a limitation of it, and that means that the chest wall and the lung wants to collapse, but because you have volume, that don't allow them to collapse. So all this, how is it going to look like on the graph? So normally, more you take air inside, and more you're going to have a certain volume that will go up to a set with pressure that will increase up to a certain point, and then you're going to have to reach a kind of plateau to it. So to reach the total lung capacity, remember, after if you go more than total lung capacity, what's going to happen? You're going to blow out your lungs. Sometimes this type of accident beginning when the mechanical ventilation has been invented. This is what happened. You inflate, but you don't know how when to stop, and then boom, the lung create fistula and then pneumothorax. So now, if you have an emphysema, what happened in emphysema? Emphysema, remember, you don't have much of exchange. The pressure is going to be very low because there's not much of pressure, but you have always constant volume inside the lungs. So it's going to be almost like the functional residual volume. So with the emphysema, you increase volume, increase. as much as possible. Remember, hyperinflation on X-rays show you that there is too much gas, too much air inside the lung, but nothing is moving much. So, and there's not much pressure that will be applying because the coil and the elasticity of the wall of the alveoli are no longer there. That is a problem of emphysema. And this is what the graph is going to be represented this way. Now, if you have fibrosis, you don't have much of tissue for exchange. If you don't have much of tissue for exchange, you don't have much of volume inside the lung. So the volume is going to decrease. But because of fibrosis, it's going to create kind of pressure inside your alveoli. And this is what encourages kind of air coming in to, you're going to have some areas that are going to be healthy, but not all of it. And this is why what you notice that the volume, this is what the lung is going to collapse. The volume is going to be lesser. And so you don't have much of total lung capacity in it because it's mostly a scar tissue. Simple as that. It's like if you take a balloon and the normal balloon inflate this way, and then you start to kind of burn it sideways, so you don't have much of expansion of it. This is what's going to happen. Or it's too thin, so it's going to just have much of volume because the expansion is going to be maximum, and then it can create fistula. And this is why emphysema, sometimes you might have a pneumothorax or you might have a subcutaneous emphysema because of it. The wall are too thin, and all the fusion between the alveoli do not make it elastic. So remember this type of graph once again. So the different type of volume that you know here, just the definition of them, I suggest you to know those definitions because they are asked as definitions. Sometimes you don't, you're not aware that they're asking definitions in the cases. But they will mention, for example, you have a first expiratory volume, and what does it mean? Or they give you a value of it, and then they will tell you what is your diagnosis. So either it's restrictive or non-restrictive type of conditions, and that is pretty much the definition of it. If you have an FEV, remember this is mostly air that is going to come out from the first second, and then you're going to look at the first capacity of it, and then you're going to have how much air per second is going to be coming out. So it means if it's this problem, this individual has an expiratory dyspnea, it's going to be very hard for him to exhale within the first second a lot of volume. So this is how you need to look at it. Here's the same thing, is about definitions, so go over them. This is the basic stuff. So dead space. The dead space is everything that has air but is worthless. It doesn't do much. It's just there. And that's what you're going to look at. You need to know, first of all, the value, as we saw in the question earlier. So you need to know the value of the dead space. And keep in mind that you have two types of dead space. You're going to have the anatomical dead space and physiological dead space. So the anatomical dead space is all the bronchi, all the from the trachea up to primary, anything that is bronchi, you're going to find air inside, but it is not part of the gas exchange. So the bronchi that is not part of the gas exchange, you can consider it as anatomical dead space. The physiological dead space is the volume of the airways and the lung that are not participating in the gas exchange because, for example, the residual volume is just an air that is there, but you don't exchange it whatsoever. And sometimes what's going to happen, and especially when people die, and you're going to think about ghosts if you're not used to it, but during the hours that will follow the death, you're going to have this individual that are going to start to do, because all the lungs start to collapse and all the residual and physiological volume are going to start to come come out from these lungs. And yeah, so that is part of the physiology of that this page. So don't stay next to someone that died within the next 12 hours. Um, Usual autopsy don't, but the body need to be within few hours after that you're going to feel that, hear that. So the ventilation perfusion for the physiological dead space is going to be uh, important because these are, for example, the apex of the lung. You have a lot of air there. You don't have much of perfusion, but you have a lot of air. But that air does not collaborate with the gas exchange. So this can be a question: where do you find the most the physiological dead space? And think about the apex of the lung. So the anatomic dead space, that is something like 150 mil that you saw earlier in the formula for calculation. The overall dead space, which is part of the physiological dead space, um, you don't have much volume. The volume that you need to know is the anatomy of that space, and the total of that space is going to be the association between anatomic and physiological dead space, or overall dead space, and which give you the total dead space. Keep that in mind as well. So in a normal lung, physiological dead space should be equal to an anatomical dead space because these are the area of still. One is volume, one is structure. So the calculation, sometimes you don't need to know the calculation, but you can have it as the physical dead space divided by the tidal volume or volume total volume. That is the difference between the CO2 within artery and the alveoli divided by the pressure of the CO2 within the arteriole. So that is a mixed air. But the only thing that you need to know in here is mostly the definitions and the value of the anatomy of that space. That's all. Okay, so respiratory volume. These are the formulas for that come from it are super important for you to know because you're going to have calculation to do about this. So they have many type of scenario going from that. So to understand better this is better to understand this type of graph. And this type of graph, if you understand it, you and know it, you can deduct your own formulas that goes with it. So obviously you're going to have total lung capacity, which is around 6,000 mil. This is a value that you need to know. Actually, all the value in here is better to know. So the total lung capacity is 6,000. What does it mean? Total lung capacity is the association between the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume plus the residual volume. So we saw that the reserve volume is everything that left behind that does not move much, and that is the part of the dead space that is 1200. And then you're going to have the expiratory reserve volume is everything that you're going to ask your patient to all the air that they can take out of the lung by forcing. And why by forcing it? Because this is the reserve, what left there but can move. And that is as well 1200. The volume is the air that you breathe in, breathe out without thinking about it. And this is what you are doing right now. And then you have the inspiratory reserve volume, which is the forced inspiration that you're going to take to ask your patient to do. Breathing, 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 breathing until they cannot breathing anymore. And what you notice is that the inspiratory reserve volume is much bigger than the expiratory volume. Why? Because you have the reserve volume that play a role in here. So from there, what you can do is you can calculate vital capacity. Vital capacity means that this is a must-have within your healthy lung to have a good exchange of gases and good volume with the gases, good compliance and good elasticity. And the vital capacity is going to be the association between the inspiratory reserve volume plus the volume plus expiratory reserve volume. Remember that the residual is not part of the function because it's air that is not exchanged. So vital capacity, once again, it's a for 800 mil. That is inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So from there, you can deduct anything that is inspiratory capacity, how much air you can have. And that is including what you breathe in, breathe out, without thinking about it, plus what you can take inside your lung. So it's going to be the inspiratory reserve volume plus tidal volume. The functional residual. See the term residual, it means what left. So residual is going to be expiratory, what you can take out as air, plus what is going to be left behind, the dead space and stuff. So if you calculate those two, expiratory reserve plus residual is going to be 1200 by 2, is going to 2400. And same deal for inspiratory capacity, take the tidal volume plus the inspiratory reserve volume with 3100, and you're going to find 3600. So the different question can come as you can calculate the tidal volume. Remember, the tidal volume normally can be should be always the same, but sometimes it can vary. But they can come with, for example, giving you a vital capacity that is 4,800 for a guy that has a total lung capacity of 6,000, and then they will ask you for a normal tidal volume to calculate the inspiratory reserve volume. So you need to use your formula. You need to use this graph to deduct your own formula, and with the material that they gave you, you can and you should be able to answer the questions. So all the spirometry graph will be almost the same, almost like this one, or can vary a little bit, but doesn't matter. What matters is going to be really the this what it represents. So this is how the tidal volume is going to be represented. This is the expiratory reserve volume, and what you notice that the graph do not go to the residual; it stops at the residual. And then you're going to have from here to the peak and going down. This is what represents the tidal volume plus the inspiratory reserve volume, which is the inspiratory capacity. All this is a respiratory capacity, and then tidal volume. Yes, I agree. It's sometimes they can be confusing, but time-consuming. I agree because you need to calculate, and usually the numbers that they're going to give you are straightforward. If you know your formula, go directly and you can find it. And if you know the base, these numbers, you can compare it to this number and tell yourself, oh, I'm wrong or I'm correct. And then look at the numbers that they give you. So sometimes the numbers that they give you are going to be numbers that are close of your calculation. These are what you're going to pick up. Yeah. But the one thing is they don't ask you that many questions about it. So if you have such a question, either if you know it, then do the very fast calculation and answer it. If you don't know it or you are confused about it, what I suggest you to do is to answer C and keep going. Remember, for USMLE, one of the trick or MBNE or whatever is when you have a question that you cannot answer, put a letter and keep going. Don't wait and don't waste time answer that question, because for that question that you might miss and you can come back to it at the end if you have time, you're going to answer 10 questions correctly. So this is they do this a lot. So this, remember, taking this type of exam is a strategy. So you know the question, you answer it, move on. Don't come back to it. You don't know the question, answer it, and come back to it later on if you have time. But if you don't have time, at least you answer it. It's not a blank. Maybe what you answer can be correct. Who knows? If you have long calculation as well, if the calculation are easy, do it and move on. If they're logic, if they're not, answer anything and then come back to it. You might have more time at the end of the exams, and this is why one thing that I'm trying to train you is to read fast, think fast, and do fast. You know, good. You don't, move on. But as a review, you need to go back to them and review them why you missed them. So know this graph, know everything that is in here is going to be pretty much handy as how you're going to do calculation. Now, if you are someone that just memorized without understanding, well, you go back to this graph and you just memorize the term and the definitions that are going on, and then you have the formulas that are going to be in here. So just remember that the capacity should be 80% of the total lung capacity. That is another way to think about it. So another graph that they can put you is going to be something similar to this one, but is exactly the same as we saw so far. So if you have it right away, recognize the different part of it: respiratory, functional, residual, vital, total lung capacity, and move on from it. Okay, so from this type of graph, this is what can happen. And these are very frequently asked questions. You can see them all the time, almost all the time. And I bet you for your NBNE, you had at least one or two questions similar to this. I will not surprise if you have more even. So Kevin Jakob, did you? Yeah, okay. For the USMLE as well, you're going to have at least one or two like this. So this is why you need to understand them to think about it. So normally, this is what's going to happen. This is the type of graph that's going to happen. Anything goes up normally. This is what represents the expiratory flow, and this is what represents the inspiratory flow. So expiratory is smooth. The inspiratory is constant by increasing volume that create a negativity in the total lung capacity. So total lung capacity goes from here to here, including expiratory and the expiratory. So when you have restrictive, what's going to happen? Restrictive means you don't have much of parenchyma. So you cannot breathe in too much. You cannot breathe out too much. You have blockage. So if you cannot bring enough air inside, what does it mean? It means you cannot take out a lot of breath. So this is how the restrictive is going to look like. The inspiratory becomes smaller, and the expiratory becomes much smaller. So it's always a triangle for the restrictive. Now, obstructive. Obstructive is there's an obstruction. So you can have air coming in, but air cannot come out. So the amount of air that come in would be the same as normal. The air that come out, expiratory flow, is going to be decreased. So the triangle disappear, and you're going to have a kind of plateau that decrease. Think of it as action potential for your muscle contraction. That's how you need to look at it. So that is obstructive. The expiratory flow is going to decrease, but the expiratory flow is going to be normal. As restrictive, everything is going to shrink. There's not much air coming in, coming out. If you have a small airways disease, meaning that you have one bronchi that is going to be an issue, so this is the area where the bronchi would be a problem. So you're going to have decrease of that amount of air coming out. Aspiration might not be a problem. If you have a fixed upper airways obstructions, then the inspiratory and expiratory might look like the same, as the picture goes. And the amount of air coming in is going to be the same amount that come out, but you have really a destruction and obstruction happening. If you have different type of airways, so it depends what type. So here, for example, in this case, you're going to have inspiratory flow that is more increased than the expiratory is going to be more increased than inflammatory. Sleep apnea. What's going to happen in sleep apnea? People take breath in, but remember they stop breathing out. They stop breathing, and this is why you have the interruption of the breath out that are going to be seen in the graph. So the graph that I suggest you to absolutely know for your step are going to be obviously the normal, restrictive, obstructive, sleep apnea, and the mixture between all these is understanding if you have obstruction within the airways. This is the same thing as the representation. So the normal, so obviously the graph might vary depending on the books, depending on but usually these are the most common one that are going to be used. This is the if you have expiratory flow that is normal, increase normally up to the level of normal, you're going to have the value of it. You have the inspiratory flow that happen, that is the volume capacity, and then this is the residual volume that are going to be in the middle, and the whole thing is going to be total lung capacity. So in case of emphysema, as we see it in obstructive, you're going to have a normal inspiratory, almost normal inspiratory. Air can come in, but air cannot come out. The same thing as here. It starts to come out and then it's blocked. If you have one bronchi that are going to be obstructed, so you're going to have less air and less volume as inspiratory that comes in. This is almost the same way as this one, almost, or as restrictive. If you have a fixed upper airways obstruction, it's going to be the fixed upper airway obstruction. This one, the same way. Air that come in is air that come out. And then you're going to have the different ways. So you need to look at your condition, and if this your condition do have an issue of inspiratory or do have an issue in expiratory, and you go from there. Restrictive parenchymal lung disease, for example, fibrosis, you have this restriction, you have a decrease of volume overall, and that is why you don't have much of inspiratory versus expiratory. If you have neuromuscular weakness, so it means the diaphragm is going to be weak, the intercostal will be weak, the accessory is going to be weak, so you're going to have less air going in, less air coming out, and this is why you're going to put them under the machine, the ventilator. Okay, so know these. This is pretty much real logic when you look at it. So another representation of the pulmonary function testing, same deal, the flow versus, here's the flow versus volume, not pressure. So what you're going to have, in case of emphysema, a limitation of air, so it's going to be representing almost the same thing as the obstructive in here. Boom, doesn't inflate too much, and then decrease. So you don't have much of, see the volume, you have a lot of air inside and hyperinflation, but you don't do much with it. Asthma and bronchitis, you have a little bit more, you have a hyperinflation going on. And remember, it's mostly expiratory problem. So you're going to have more, it's going to take more time for it, and the flow is going to be pretty much really limited as coming out. So this is mostly expiratory issues. And notice that there's a certain volume that is going to, this is residual volume. So this is why you look at hyperinflation. Now, normal individual, remember that the total lung capacity would be 6, so this is what it's supposed to be. And when you take the breath in, you're going to have flow up to 10, and then decreasing regularly, and until almost zero. Remember, that is residual. In case of upper airways obstruction, so DFEV 50 would be around here. It's going to be around 3.5. So if you have the upper airways obstruction, so it's going to take time. The inflation total capacity will be normal, but it's going to take time for the expiratory to happen because you have an obstruction. And that area that is an obstruction can have residual volume. But you cannot, because of the obstruction, you cannot go to the maximum flow. It's going to be even lesser than the emphysema. But you have a kind of plateau happening. So the two one that give you hyperinflation on the X-rays, or you're going to have air inside of the alveoli that left because they cannot come out, would be the asthma and the emphysema. So keep that in mind. If you don't remember all this, just remember hyperinflation X-ray. So it means I have more volume in the alveoli. X-ray look like darker, and this is why I have more volume. So this one, and remember the emphysema will have more volume than the asthma. So if you have to choose between the A, B, C, D, well, it's easy to look at it. Pulmonary fibrosis. Pulmonary fibrosis, one thing that you look at it is there's not much air whatsoever. There's a fibrosis. Very little of normal parenchyma is happening. And when they breathe out, they can go up to almost zero. This is the only one that goes almost to zero. And it's the only one that you have a very limited amount of fluid. So, and when they expand their lungs, they can expand it up to, because air can flow normally, is mostly within the alveoli that the problem is going to happen. But you have a limitation of how much expenditure you're going to have. This is why it's almost like the normal, but the FEV is 75% in those situations. So know this graph for respiratory, they are the highest yield thing. The alveolar ventilation rate, how you calculate that? What does it mean? First is the air that is going to move within the alveoli. So since its volume is milliliters per minute. So flow of gas doesn't mean gas exchange. The gas exchange comes after. Flow of gas, it means you have normal inspiration, expiration, or you don't. If you don't, it means you look at it as a restrictive or you look at it as an obstructive. And this is why flow ventilation rate is going to be very helpful to know how much air is going to be allowed to have the exchange. And the calculation is going to be as the frequency of the breathing multiplied by the tidal volume minus dead space. And that was the one of the questions that I asked at the beginning today. So it's going to be around, normally it's supposed to be around 6. Well, it depends because you remove the dead space, so it's going to be around 4.2. So slower you're going to breathe, more you're going to increase our ventilation rate. And rapidly you're going to breathe, like for example tachypnea, less air you're going to have, so less breathing you're going to have, because the alveolar ventilation rate is going to decrease. This is why, like I said yesterday, we don't know how to breathe really, because we breathe by the nose, by the mouth, and breathe by the abdomen or not, and we don't take our time to breathe. We just breathe in, breathe out, breathe in, breathe out, without thinking about it. Unless you become athlete, then you start to learn how to breathe. And remember, every time you feel or you are conscious that you are breathing, it means there's a problem. It's like eating. If you are conscious that you're swallowing, it means there's a problem, which you need to address. And that is what you need to look at any patient that are going to complain, or any of your cases, for exam or not exam, that is real life. So the response to high altitude, we went over this just very fast now. Ventilation is going to increase because you need more air. Sensitivity to central receptor are going to be there because CO2 increase and oxygen decrease. Carotid bodies, which are the baroreceptor and chemoreceptors, are going to be increasing. Erythropoietin will be produced to have more RBCs. And remember, 2-3 DPG within the red cells, the hemoglobin is going to increase to catch as much as possible as oxygen. Mitochondria are increasing to increase the respiration of the cells. Bicarbonate is going to be excreted more within the kidney. Remember, because this is a kind of balance for the pH, and you're going to end up with respiratory alkalosis because you're going to have hyperventilation. So you bring in as much as oxygen as possible, and you don't breathe out as much as only breathe out a lot of CO2. And this is why you can have pulmonary edema, as we saw yesterday, and brain edema as well. And that, but the pulmonary edema is mostly because you have pulmonary capillary pressure that are going to increase. So remember, at high altitude, the atmospheric pressure decrease and the overall PO2 decrease. Remember those? This has been questions. These are easy questions, but they know that many students are not aware of it, or they usually they never review this type of thing. And that is difference between 260 and 220. So the ventilation, what's going to happen is obviously you're going to decrease overall pressure of oxygen. There's not much of oxygen there. So respiratory rate is going to increase to bring more of oxygen for hyperventilation. And then this decrease of oxygen pressure are going to stimulate the baroreceptor and chemoreceptors within the carotid, if you remember, and that will stimulate the medullary inspiration. That will increase the hyperventilation. As the arterial blood ventilation increasing, that would increase the arterial oxygenation and decrease the arterial CO2. This is why you end up with respiratory alkalosis at the end of it. So here's the same thing, more detail. So sometimes you might have some formula that happen as the response to high altitude. For example, here you're going to have oxygen plus O2 that form bicarbonate. And remember, this happened mostly in the red cells and happened in the kidney, and that liberates plus bicarbonate. So decreasing of CO2 is shifting to the left, and we're going to see this as a graph for that. The oxygen hemoglobin dissociation curve. So you're going to eliminate as much as possible of H+, which increase the pH, which you're going to have respiratory alkalosis about that. So the kidney is contributory to that. So the pulmonary blood flow are mostly, as we saw earlier, the PO2 decreasing, leading to hypoxic vasoconstriction, and you're going to have brain vasodilation happening, and that if you have vasoconstriction of the capillary within the lung, that means that you increase the resistance of it. If you increase the resistance, means you're going to increase the pressure, the pulmonary arterial pressure, and this is what creates actually the edema itself. So the static would be higher than non-clotic. So remember as well that the heart is going to be contributory by the right ventricle that is pumped against a big pulmonary arterial pressure, which is the increase of the afterload. That is logic. And if you have a chronicity of this hypoxia, or vasoconstriction is going to become chronic, and this is what you're going to have cor pulmonale or pulmonary hypertension. In same time, you can catch up with the right ventricular hypertrophy in the long term. That is long term, not just going to high altitude. Because usually going to high altitude, if you're healthy, you catch up within 3 to 8 days. And in the beginning, you're going to have oxygen anyway. The cerebral blood flow, that is the question. So that is, remember, the cerebral blood flow is controlled by the PCO2. And contrary from the lung, if you have a lung vasoconstriction, you're going to have vasodilation as complication within the lung. But once you're going to have decrease of the pressure of CO2, that is going to lead you to vasoconstriction in the brain. So that means, obviously, we saw that the respiratory center is going to be stimulated, that lead to the hyperventilation, and the hyperventilation will decrease the PCO2. If you decrease the PCO2, what does it mean? It means that your intracoronary pressure is going to decrease the cerebral perfusion, and this is why you have cerebral edema. And but it can be temporary or can be for good, so it depends on really on the situation. So the decrease of PCO2 lead to vasodilation in the brain that increase cerebral perfusion pressure. Once again, and this is why you have the risk of cerebral edema. So just remember as the base, the lung vasoconstriction, the brain vasodilation. They go always in opposite. And both of them are going to have edema from hypoxia. As the cell, so we're going to have hypoxia, chronic hypoxia, obviously erythropoietin is going to increase. You know that by now. Hemoglobin concentration is going to increase. Hematocrit is going to increase, which is going to increase the hemoglobin concentration, which carry more of the oxygen to the tissue, and that also will allow to the increase of mitochondria. As the hemoglobin itself, you're going to have a little bit more of the 2,3 DPG, is DPG, not BPG. That will lead to the shift to the right because you have more consumption of oxygen. But the affinity for the hemoglobin for the oxygen is going to decrease. So it means you have a lot of oxygen that will be unload and a lot of oxygen that will be circulating. This is why after a while you have a shifting to the left. The ventilation perfusion, this as well is one of the many questions in USMLE as the perfusion goes versus ventilation and the VQ situation. So remember within the lung, did you have a question like this in the BNE or not? USMLE you're going to have, for sure. And BNE, I saw one question time to time coming up about this. You did, okay. So this is a zoning that you're going to have within your lung. You're going to have zone 1, 2, and 3. So zone 3, remember one thing, and this is what you need to remember really, is that there's a lot of blood flow going on. So gravity is going to push down what is heavy. So from the arterial versus the alveolar, the pressure is high because you have more pressure as the arterial than venous and then alveolar. This is the zone 3. The zone 2 is going to be a mixture between a lot of perfusion and a lot of volume going on there, so oxygen. But in this situation, you're going to have some changes. You're going to have the pressure of arterial is going to be much higher than the alveoli, which is much higher than the vein. Keep those in mind because those are the questions that they're going to trick you with. In the zone 1, which is the apex, you don't have blood flow, but you have a lot of air. So this is why it's the alveoli that you have the air that is going to take over. So the pressure of the alveoli will be much higher than the arterial, that will be much higher than the venous. So there's not much of oxygenation of perfusion that are going to happen. And this is one of the reasons that you're going to have, because, okay, there's air, but there's not much of exchange of oxygen. So this is why Mycobacterium are going to stay there. They love the air itself, but they don't like really too much of oxygenation. So they thrive in those regions. So the ratio, the ventilation ratio is going to be that normally the ideal situation would be that the ventilation should be equal to perfusion, like the zone 2, for example. And in that situation, the differentiation of volume versus flow, the VQ as we call it, if ventilation equal perfusion, you need to be equal to 1. That is the ideal. But it's not going to happen. And this is as well going to have wasting, exactly like the brain where you have vascularization that are going to affect other zone, which you call the wasted zone, is going to be happening here. So in the apex is the wasted ventilation. You have a lot of air that you don't do much with it. So the volume would be higher than the Q. In the base is the contrary. You have more perfusion than you have volume. And that, remember, gases usually goes up, always goes up. Any gas goes up. So this is why when you have a house that is burning, the first thing that you're going to do is put yourself in lower portion of the room on the floor because the gases goes up. And this is the same thing. Volume goes up, what is solid stay down. So in here, the base of the lung, the volume would be lesser than the perfusion, and this is what you call wasted perfusion. If you exercise, the VQ is going to be coming to almost to 0. Why? Because you have a lot of air when you breathe in, but also your circulation increases. So that this is why it's going to be almost 0. It's not equal. Ventilation will never become equal to perfusion, but it's going to be 0. So this is why one of the things about pulmonary circulation, keep in mind that the resistance is going to be low, otherwise you can end up with pulmonary hypertension. The compliance of the bed are going to be high. We saw that increasing, decreasing for the breathing. And anything, as we saw, anything that has a hypoxia, right away you're going to have pulmonary vasoconstriction. And the brain is going to be vasodilation, although CO2 will lead you to vasoconstriction. So keep that in mind. So this is what we talked about, a bit more detail. So as the value goes, just keep in mind that in zone 1, the VQ should be, it's around 3 because you have a lot of volume, less circulation. And in the zone 3, you're going to have that the VQ equals 0.6 because volume, the circulation is higher. Keep these two numbers in mind. Okay, and here is going to be almost the ideal, close to 1. So yeah, so this is what we talked about. And remember, when you stand, the distribution of the blood flow goes with gravity, and when you supine, the distribution of blood flow along is uniform. Okay, this is why the pressure is going to increase when you're standing versus when you're laying down. So everything that is in here is exactly what I was talking about earlier, and remember that in zone 1, this is where you're going to have a lot of more physiological dead space because you have volume that you don't do much about it. That's going to happen. Almost the same thing because I give you here some numbers. You don't have to remember these numbers beside the 3 and the 0.6 overall, but sometimes, rarely, you have some question that ask about volume. These are nasty type of question because you don't remember the volume, don't remember the numbers. But remember that below, going closer to the base, the flow will be 5 milliliters per minute. Going towards the apex, the flow will be 0.56 per minute. And in the base, the flow will be 10 milliliters per minute. So now, the normal distribution will be like this of the perfusion. That is the normal situation. Now, in case of cardiac output that is increased, the volume within the zone 3 is going to increase, obviously because you have more blood flow going on. So you're going to open up the shunts. If you have a decrease of cardiac output in case of heart failure, what's going to happen? You have less perfusion of your lungs. And what you notice in here is that when you have an increase of the output, you don't have much of zone 1, as if it was a normal distribution perfusion. But with decrease, this is where the zone 1 start to happen. An increase of pulmonary vascular resistance, so the blood flow are going to decrease, but without any increase of cardiac output, you're going to notice that the resistance make it as if it was a decrease of cardiac output. And you have the zoning happening in that situation. So this is why when you have pulmonary hypertension, you have more air than you have perfusion. And that is an issue because if you don't have much of perfusion, you cannot have gas exchange, and you end up with hypoxia and cyanosis. Make sense? So same deal, just showing you the different ways. So sometimes in some graph, they're going to represent the blood flow versus the distance. And that will tell you what are the zoning. So obviously, if you see more volume, this is going through zone 1. If you have more blood flow, that is most closely to zone 3. And these are exactly what you need to answer for this type of questions. So there's not much to think about in the situation. So flow distribution is going to depend as well as cardiac output because remember, one way the heart send the blood and the other way receive the blood. So it can become a resistance versus it become cardiac output. So anytime you have what is going to have an influence on the flow or the pulmonary output is going to be depending if it's venous or if it's arterial. So right heart versus left heart. So if you have a decrease of pulmonary vascular resistance, you're going to have decreased pulmonary vascular resistance. So it means you have not much of blood. You have volume, but don't have much of movement. So you're going to have hypocapnia, and you have pulmonary vasodilation. And the pulmonary vasodilation will be caused by nitric oxide. If you have an increase of systemic vascular resistance within the lung, think about hypothermia can lead to that. Vasoconstriction can lead you to that. So contrary from the decreased resistance, here is increased resistance and sympathetic stimulation. If it's a systemic output, so from the left-sided heart, if you have pulmonary vascular resistance, the causes are going to be a bit different. So you're going to have hypoxemia, hypercapnia, high hematocrits, cold, the positive pressure within ventilation. Be careful, this can be a question. Positive pressure of ventilation increase pulmonary vascular resistance, which need to increase ventilation. Metabolic acidosis can lead to the same deal, and the alpha-adrenergic is going to increase pulmonary vascular resistance. Remember those, which is going to decrease the systemic. So resistance will be vasodilation, so it's contrary from the pulmonary one, which is vasoconstriction. Spinal and epidural anesthesia. Remember this. It has been a few questions that I saw. The deep general anesthesia as well goes with epidural. All the anesthesia will be the same. And contrary from the increased vascular within venous, is going to hypothermia, and here in the arterial is going to be hyperthermia. So the contrary. So anything that is arterial will be the contrary what is the venous. And remember, within the lung will be arterial, but it's CO2. So normally the VQ is going to be almost close to 1, which is 0.8. Remember this number. And also remember that the PaO2, the value is around 95 to 100, and PaCO2 will be around 40. Those are numbers that you need to know. So if you have a mismatch or you have a ventilation perfusion matching with ideal, you're going to have it, like I said, closer to 1. So if you have an exercise, if you exercise and you increase your cardiac output, which lead to vasodilation of the apical arteries, like we saw in the graph earlier, the VQ is going to be closer to 1. So that is the ideal. So exercising is good for the lung, it's good for the heart. But be careful, there's limit as well. So the distribution is that the VQ is higher in the apex, as we showed you earlier, especially if you're upright, standing, is going to be around 3, and you have a lot of wasting. As a zone 3 is going to be 0.6, as we saw it earlier, and that is wasted perfusion. So keep those in mind. The big mismatch is going to be the dead space, because the dead space value is going to be, these are values that are big, and perfusion is almost none. So you're going to have an infinity to it. For example, if you have pulmonary embolism, be careful this one. If you have pulmonary embolism, which you don't have much blood flow, then you consider it as if it was a dead space, which becomes dead space because it's an area that is worthless. So there's no perfusion, but there's ventilation going on. There's air there, so this is a wasted ventilation, and you call that a physiological dead space. But the big problem is there's no gas exchange whatsoever. And remember, physiological dead space, so the dead space is going to be 150. So PO2, the overall CO2 is going to be 0 as much of the oxygen going on here. But if you give a patient 100% of oxygen, that is going to improve the arterial oxygen, but not the overall one. The shunts are dangerous sometimes, but the VQ for shunts equal 0. Shunts usually going to have that every time you have an obstruction, vascular obstruction or lung obstruction. And so if, for example, one of the big case would be ARSD, the ARDS gas. That look like a shunt, so the perfusion is going to decrease, but actually in those situations you're going to have perfusion, but you don't have ventilation because the area is shunt, is you have an airway obstruction. So this is mostly a wasted perfusion that do not match with the ventilation. There's no gas exchange once again. So this is a question that has been asked. What is the difference between a shunt and a dead space as a VQ? And the difference is that in the dead space, when you give 100% of oxygen, that is improved the PaO2 value. In the shunts, if you get 100% oxygen, that does not improve the PaO2 because there's not much of circulation with it, since there's no exchange whatsoever. And most commonly, you're going to have mostly venous blood type of, since there's no gas exchange whatsoever, the situation. So keep those in mind. These are high yield type of questions. Okay, guys, I think we're going to stop here today. And tomorrow we give you time to review what we did so far. And tomorrow we're going to talk about the cycle of breathing and the dissociation curve and stuff like this. And we keep doing questions tomorrow as usual. I think questions are helping you a lot to see your weaknesses, and this is a refreshment for what you need to know. Okay. and we go from there.